The section over abdominal defects goes into way more detail than what you really need. The assignment for this week, the worksheet assignment, is going to force you to look through the chapter to answer those questions, but by far I don't want you to memorize the details. So this PowerPoint is going to summarize the key points that you need to know. Congenital diaphragmatic hernia. This is a term you need to understand what it means when you hear it. When this occurs, segments of the diaphragm fail to fuse by the 8th week of gestation, meaning there's still a hole in the diaphragm. The abdominal contents then herniate or protrude through the wall into the thoracic cavity. So if you look to the picture, the baby on the right has the hernia, and if you locate the diaphragm, you see his liver and intestines are actually up in his thoracic cavity, and so you can't even really see his left lung. Lung hypoplasia, organ or tissue underdevelopment, will also occur where the intestines have herniated on the affected side. Lung tissue and capillaries will fill or fail to form based on the amount of space lost to the intestines. The clinical complications associated with a congenital diaphragmatic hernia are pulmonary hypoplasia, patent ductus arteriosus, patent foramen ovale, malrotation. Most obvious physical findings for a newborn with CDH is a scaphoid abdomen. Scaphoid abdomen. Make note of that term because anytime you see that on a case study or a scenario, that means they have a congenital diaphragmatic hernia. A convex belly because the abdominal contents are in the thorax. Hypoxemia leading to hypoxia. An oxygen index of greater than 20. There's concerns regarding the patient's ability to oxygenate despite high levels of support, pulmonary hypertension, and cardiac insufficiency. Now, by no means should you memorize all of these items. You should keep in mind that you're going to have some lung abnormalities, possibly some open ducts in the heart, and then remember the scaphoid abdomen. The rest is, knowing there's going to be hypoxia is pretty common sense. The delivery room management, if you know ahead of time that the baby being born has a congenital diaphragmatic hernia, then you should anticipate and prepare for the baby to come out in respiratory distress. So if you know about it before delivery, you want to be prepared for immediate intubation before the baby starts to become hypoxic or hypercarbic. However, not always do we know these things. So you never want to bag, mask, ventilate the baby because it's going to force air into the stomach and intestines, which then is going to further compress the lung tissue and exacerbate respiratory distress. So the first thing you want to do is insert a nasogastric tube, which the nurses or nurse practitioner or physician, neonatologist, would put in the nasogastric tube, and that allows air to escape out of their stomach and intestines, and then you can start bagging. So it's not that you're never going to bag these babies, it's that you don't want to do it until you have the nasogastric tube in place. And then if they become hypoxic, you should use 100% during ventilation. Pre-operative management, so obviously these babies are going to need to have surgery to put the intestines back where they belong. So before they go to surgery, our management of the patient is going to focus on hemodynamic stabilization and respiratory support. So help them breathe and keep their blood pressure stable. You want to avoid hypoxia, acidemia, and minimize the possibility of an iatrogenic lung injury. This is a lung injury which is caused by medical professionals, typically mechanical ventilation. Again, some of this is kind of obvious. Now, you're learning about ventilator management in your vent class, so we're not going to spend tons of time on vent management here. You should know that you can use a conventional ventilation. Oftentimes, if a baby is significantly hypoxic, or if they have a patent ductus arteriosus, or if they develop pulmonary hypertension, then you're going to start your high-frequency ventilation or your oscillator. You could be doing some surfactant if there is a surfactant deficiency. If they have persistent pulmonary hypertension or PPHN, then we might need some nitric oxide or some other vasodilators. They could require the use of some inotropes, some agents that improve cardiac contractility. And then they're going to need some analgesia and paralysis. Last case scenario or worst case scenario would be ECMO. Okay, again, so for congenital diaphragmatic hernia, know the key points. You don't need to know strong details. With any condition with a neonate, you're going to want to minimize peak pressures. PEEP, we never go above 8. You want to be conservative on your FiO2. Like that's straight across the board for every neonate ventilator management period. Okay, gastroschisis. This is another abdominal wall defect, and it's characterized by the protrusion of the intestines through the abdominal wall, and it's not covered by the amnion. So if you see the picture to the right, it looks like the baby's intestines just fell out of them, and that is exactly what it looks like. I was going to put real pictures in here, but I didn't want anybody to get grossed out. The defect develops between weeks 3 and 8 of gestation. That is not important. Diagnosis is normally made during fetal ultrasound. Again, not important. Maternal risk factors include cigarette smoking, malnourishment, recreational drug use, specifically methamphetamines. That is important. White and Hispanic mothers are at higher risk, and maternal age less than 20 years old is another common thing. Delivery room management. At delivery, the newborn should be placed in a sterile drawstring bag, also known as a bowel bag. Yes, you're hearing that correctly. Obviously, you're not putting the baby's head in the sterile drawstring bag, but you're putting the rest of their body in the sterile drawstring bag to protect and keep the intestines sterile. So, the bag is there to protect the bowel from contamination and infection, as well as prevent fluid loss. Again, we do not put the plastic bag over the baby's head. A nasogastric tube should also be placed to minimize distension, and then temperature regulation is going to be important because these patients are going to be more susceptible to hypothermia, because of their intestines being exposed to the environment. An omphalocele is a midline defect with the umbilical cord rising from the middle. The small intestines, liver, and stomach are frequently herniated organs that are encapsulated by the peritoneal sac. Common abnormalities with an omphacele include cardiac, cranial, and urogenital defects. Management and treatment. Again, this one you also want to put a nasogastric tube in place. Put it to suction for decompression of the entire gastrointestinal tract. Initial management is going to be similar with that presenting with gastroschisis. Care must be taken to protect the defect from contamination should the sac rupture, and again we would use a bowel bag or a sterile drawstring bag to cover that and protect it and keep it clean until it can be taken care of. So notice the overall treatment for any abdominal defect: put a nasogastric tube in to get the air out of the tummy before you start bagging. Again, low peak pressures best you can. You can use the oscillator on all of these conditions, and remember the PDA and PFO, patent ductus arteriosus, patent foramen ovale, are often accompanying with your congenital diaphragmatic hernia, as well as persistent pulmonary hypertension. And if that occurs, your persistent pulmonary hypertension, that is the only time that you would add the nitric oxide or other vasodilators. Okay, that's it for this one.